So, welcome back. Today, I'll be discussing an approach to chest pain in our series on symptom analysis. So, this is how I generally approach chest pain. First step is always to rule out an acute aortic syndrome or pneumothorax. So, these are two conditions that happen or develop within seconds to maximum minutes, and both of them can be life threatening, particularly if the pneumothorax is a tension pneumothorax. Okay. So that is why it is important to consider them and rule them out as soon as possible. Now, if there is any clinical inkling that they may really be present, then we typically go immediately for imaging. So it's best not to waste any time. In that case, the contrast enhanced imaging of the thoracic aorta and abdominal aorta is what is indicated. So after that, if it has been ruled out or if it is unlikely, then we go on to step 2. So step 2 is to consider the underlying mechanism of chest pain that might be there. So there are 4 possible chest pain mechanisms. The first is activation of special visceral efferents, nerves that arise from the cardiac plexus. So these include nerves that actually arise from the cardiac plexus but go into the thoracic spinal cord at T1 to T4 spinal levels. Okay, and so this is the distribution of the spinal involvement. The second mechanism is activation of somatic efferents. So obviously visceral efferents, they don't localize very well. Okay, so they localize poorly. The brain is unable to decide where exactly the signal is coming from, so that leaves a lot of overlap between different dermatomal territories, and that causes a lot of confusion. Whereas somatic efferent nerves, they have a one-to-one exact point-to-point localization, so the patient is usually able to tell where exactly is the pain. Okay, so that is something that helps us a lot. So what I do is, in my diagnostic approach to chest pain, I usually use this property to help delineate whether or not it is coming from your pericardium or similarly coming from the parietal pleura, because both are supplied by somatic afferent nerves, and therefore they have a one-to-one exact localization. On the other hand, somatic nerves also supply the chest wall, again providing a very specific localization, and the patient is often able to tell you exactly where the pain is coming from. Okay, so this is normally how I approach any symptom. Okay, but particularly pain, I go with the mnemonic OPDSR SCAR. Okay, now there's a reason why I go through the characteristics of any symptom like this. The reason is that your sensitivity is maximum here and minimum here. Okay, so it decreases progressively as you go from onset to relieving features. On the other hand, the specificity of a particular complaint, as in how frequently do you get that complaint, as in it's not a very frequent thing that the patient tells you, but if the patient does tell you, it is highly relevant and it is very relevant to your evaluation. That is maximum here, that is in the aggravating and relieving factors. So however, onset progression can sometimes be specific, but usually are not. Okay, and since we have started with ruling out acute aortic syndromes and your pneumothorax, in that particular situation, onset and progression are somewhat specific, but usually in most symptoms that is not the case. Okay, so this is the reason I use this particular sequence of analysis in all symptom analysis, and you can try it for yourself and see how useful it will be. So first step was to rule out acute aortic syndromes or pneumothorax. So for that, historically, what do we look for? So I'll compare it to the prototype of chest pain, that is your acute coronary syndrome, and I'll be comparing it to an acute aortic dissection and a pneumothorax. So starting with onset, obviously our acute coronary syndromes typically have a acute onset. So within, usually the patients who have what we term unstable angina, and we'll be coming to that, have a symptom duration of more than 10 minutes to up to hours. Okay, the progression is variable, but often is progressive. The duration per se, all of these pathologies are acute, so it doesn't really differentiate. Okay. On the other hand, acute aortic dissection is seconds to minutes, and the progression is very rapid. Pneumothorax is a few seconds, and usually it is very severe in the beginning, but it just stays that way. So it is usually non-progressive in severity of pain. Okay. Now site. See, acute coronary syndrome is the pain is retrosternal typically, although this is not always the case, because as we discussed previously, it is because of activation of special visceral efferents which don't localize one-to-one to a particular part of the body. So the brain is not able to delineate that it is coming from this particular location within the body. Whereas your acute aortic dissection in pneumothorax, they activate your somatic efferent. So as a result, the pain is highly localized. Okay, so in case of acute aortic dissection, it is midline chest or abdominal pain, that is retrosternal, and in case of pneumothorax, it's always lateralized to one side. Okay, so it's a lateralized pain. Now the next thing is radiation. So in radiation, because the cardiac plexus arises from T1 to T4, because the cardiac plexus arises from T1 to T4, other dermatomal inputs into this spinal segment also get activated, or the brain gets confused that it is coming from other dermatomal distributions from T1 to T4. Okay, so that would, T1 being the inner arm, so it would come from either inner arm. Okay, so typically it is more the left arm than the right arm, but the right arm can be affected, and everybody's cardiac plexus is actually slightly differently innervated. It can sometimes be from both arms. It can also go right up till the neck. Okay, usually not crossing the neck and not going below the umbilicus. Okay, so on the other hand, in acute aortic dissection, the patient gives you a very characteristic history of the pain going back towards the midline back. Okay, and this is something that is very characteristic. Usually a pneumothorax pain does not radiate. Now in terms of severity, all of them typically are very severe, and you cannot really differentiate. The character of acute coronary syndrome pain is, it's a characteristic, heaviness or constricting pain in the central retrosternal chest, whereas that of aortic dissection is very sharp. So the patient feels a very sharp, almost sometimes described as tearing, okay, pain in the center of the chest. Similarly, the pain of a pneumothorax can also be tearing, but it gets worsened when the person takes a deep breath, so that they sometimes describe as a catching type of pain. Now, aggravating and relieving features for acute coronary syndrome depend on what type of acute coronary syndrome we're talking about. But okay, specifically, they are increased with activity and decreased with rest, and we'll get into the the weeds of it later in the video. There are no clear aggravating or relieving features associated with acute aortic dissection or pneumothorax. Okay, so with this in mind, we typically are able to quite definitively say that there is a possibility of an acute aortic dissection or a pneumothorax. So we also sometimes are alerted to the possibility of an acute coronary syndrome, but if you are not suspecting either one of these two pathologies, then there is another step that you must cognitively undergo before you go and go ahead with your workup. So as I've discussed, there are 4 different mechanisms of generation of chest pain sensations from the chest. One is activation of your special visceral afferent nerves. So special visceral afferent nerves are those nerves that supply viscera, okay, and they do not pass through your dorsal column lobe medial lemniscal pathways. Therefore the brain is not able to directly say that the pain is arising from this exact location within the body. Okay, whereas pain can also arise from somatic afferent nerves, either supplying the pericardium or the parietal pleura or from the chest wall. Now the brain is able to exactly say that the pain is coming from this exact location. Okay, so if the patient is able to localize the pain well, then typically it is quite easy for us to differentiate. Okay, so let's see what happens. So in step 2, what we do is, first we'll just describe the different types of pains. So like I just said, pain arising from nerve, from activation of nerves which at least partly are part of the cardiac plexus, is usually appreciated by the patient as a retrosternal pain. Okay, it radiates to the left arm more than the right arm, sometimes to both arms, and can go right up to the angle of the jaw. Severity is variable depending on what exactly is the cause. So like I've just discussed, those nerves supply other areas as well. So the primary pathology is not necessarily cardiac. Okay. On the other hand, when your pericardium or the parietal pericardium somatic nerves are activated, then the pain is the parietal pericardium, being a retrosternal structure, is felt retrosternally. Okay, but it radiates to the trapezius, the bilateral trapezius muscles. Okay, and that is a very characteristic thing about pericardial pain. The pain from parietal pleura activation, arising from parietal pleura, resulting in activation of somatic efferent nerves, is lateralized to one side of the chest. So it is somewhere around the lateral chest wall, and the patient is usually able to see that the pain is deep. It's not next to the skin. Okay. On the other hand, the pain arising from the chest wall, which is from other structures within the chest wall, obviously every other structure in the chest wall is superficial to the parietal pleura. So whether it is a muscle spasm or a muscle pain arising from the periosteum of the ribs, or pain arising from the costochondral junctions, okay, all of that, or even the skin and the subcutaneous tissue, will be highly localized and superficial. Okay, so the patient often points to the site of the pain. Now, the severity again is very variable and is not a very useful characteristic in differentiation. The character is quite specific, because pleural and pericardial pain is often stabbing or catching in nature. The patient calls it catching because when they're taking a deep breath, suddenly they stop taking the deep breath because of increase in pain. So it's a catching type of pain. Okay, and on the other hand, the activation of somatic efferents from the chest wall usually produces a dull aching pain. Sometimes over the skin it can produce a burning pain, particularly with herpes zoster. Now, again, the mechanisms that result from somatic efferent activation have distinct mechanical aggravating and relief features. So the change in mechanical forces experienced by the chest wall, the stress wall structures, or the parietal pericardium or the parietal pleura, they are very apparent. It's something mechanical that induces this kind of worsening of pain. So this is not the case with cardiac plexus origin pains. So that is something that will become very apparent in our specific discussion in the next slide. However, when it is the pain that is arising from your parietal pericardium, if you lie down, okay, the parietal pericardium becomes in contact, because the heart moves posteriorly under gravity, and the parietal pericardium comes in contact with the visceral pericardium. Okay, and that increases the rubbing of the two inflamed surfaces against each other in cases of pericarditis. Okay, similarly, in case of parietal pleural involvement, if you lie on the side that is contralateral to the pleural, to the side of the pleural pathology, as we've discussed in our discussion on chronic on shortness of breath. Okay, so in that, what happens is, now the during inspiration, the visceral and parietal pleura rub against each other, and that creates the pain. Okay, similarly, on lying to the side of the pleural pathology, the chest wall gets stunted. The chest wall gets stented, and as a result of that, what happens is that the visceral and parietal pleura don't rub against each other as much. So as a result, the pain decreases. Similarly, if it is arising from the chest wall, just applying local pressure to the chest wall makes the pain significantly worse. Okay, so local pressure to wherever the patient says the pain is coming from this particular area, you press there, the patient will wince, the patient will have pain. Okay, now what might be the cause of this kind of activation? So if you are thinking of pericardial origin pain, there is only one reason, that is pericarditis. Okay, if you are thinking of pleural origin pain, there is a possibility that it may be pleuritis, it may be pneumothorax. Okay, but again, like I discussed earlier, with pneumothorax, it is very, very sudden. With pleuritis, it is more acute to subacute. So pneumothorax, if it is minor, can also be slightly, the onset, progression, duration might be little delayed. So that is why it is also a consideration here. Now, the other pathologies that can result in secondary inflammation of the pleura is you can have a infarction in the lung, so pulmonary embolism. You can have inflammation within the lung, which is involving the pleura secondarily in case of a pneumonia. Okay, and you can have a malignancy directly infiltrating the pleura, and then the visceral pleura, and then the parietal pleura in case of a malignancy. One example, a special situation in which you get a type of pulmonary infarction is a sickle cell disease crisis. So that is called an acute pulmonary syndrome or sickling crisis. Okay. Now, in the chest wall, any structure within the chest wall can produce pain. Okay, so you could get costochondritis, you could get herpes zoster related skin involvement, you could get osteitis. Okay, like I discussed earlier, you could get a muscle spasm. These are all possibilities when you have a chest pain involving the chest wall. Okay, you could even get neural pain in the distribution of the chest wall. All of these things, the patient will say exactly where the pain is coming from. Now, once you have in step 1 ruled out your acute aortic syndromes and your pneumothorax, and in step 2 ruled out pain that is arising from activation of somatic efferent nerves, either from the pericardium or from the pleura or from some part of the chest wall, you are now suspecting that the pain is arising from the nerves that supply the cardiac plexus. Now, it need not be from the nerves directly from the cardiac plexus. It could also be in the same dermatomal distribution. Your brain is not able to differentiate. So we'll have to go a little bit into details of what that might be. Okay. So I've just discussed the causes. In case the somatic efferent nerves are activated, are very specific and allow easy differentiation. Now, before we go into activation of the cardiac plexus, see, one major and very important life-threatening situation in which the nerves from the special visceral efferents from the cardiac plexus, okay, can be activated is when you have infarction of the myocardium. So now, or impending infarction of the myocardium. So that is what is termed unstable angina, and there is a very specific way to define unstable angina. What is that? The presence of any one of the following, that is pain that has been persisting for more than or equal to 10 to 20 minutes after cessation of exertion. Okay, this is to differentiate it from chronic stable angina and other causes. Okay, now pain that is present at rest or with minimal exertion, pain that increases progressively in terms of severity and or duration during the past 1 week. Okay, and pain that is not relieved with sublingual nitroglycerin or other things that cause epicardial coronary artery dilatation. So all of this defines unstable angina. So technically this is like a step 3. Okay, when you're thinking that it's the cardiac plexus origin nerves that are activated, you must first consider whether or not it fits into the definition of unstable angina. If it does, then you have to be very, very vigilant for the possibility of ischemic cardiac pain. Okay, now, what might be the cause of this kind of a special visceral efferent activation arising from or at least in part from the cardiac plexus? So it might be due to myocardial ischemia, obviously because the myocardium is supplied by the cardiac plexus. It may be due to myocardial inflammation, again because the myocardium is supplied by the cardiac plexus. Now I said T1 to T4. Okay, so it could also be there from the special visceral efferents that arise from the esophagus. Okay, so or even the proximal parts of the stomach. So it could be from foregut structures like the esophagus. So esophageal ischemia and esophageal inflammation would also cause this. But see, the esophagus is not affected by activity. It is not affected by its blood supply is not affected by increased physical activity or decreased physical activity. It's a different type of pathology. So it behaves differently when you look at it through the lens of aggravating and relieving features. So we'll come to that. Similarly, pancreatic inflammation, the pancreas being a foregut structure, also can be, can mimic activation of nerves that are arising from the cardiac plexus. As a result, these 5 pathologies become, differentials of what we call unstable angina. That is why I like to, put patients into the bucket of pain arising from possibly activation of nerves that would, arise from the cardiac plexus. There is then divided into 2, that is your unstable angina and then others. Okay, so if it fits into unstable angina, go in for an ECG, go do a TROP-I, or a TROP-T, and do it serially, okay, and monitor the patient for at least 12 to 24 hours. Now, usually if there is any doubt, the cardiology team also should be evaluated. When it is not fitting into that, even then, taking risk versus benefit into account, we'll discuss the in some situations we need to be very vigilant for unstable angina, particularly if the patients have have risk factors for ischemic heart disease. Now so myocardial ischemia, as we'll come to, can be due to unstable angina or non-ST elevation or ST elevation MI, both of which come under the broad heading of acute coronary syndromes. It could be due to tachyarrhythmias. It could be due to hypertensive emergencies. Okay, so tachyarrhythmias, the heart rate increases so much that that diastole duration is decreased, and as a result, as we know, cardiac perfusion occurs during diastole, so that perfusion decreases. In case of hypertension emergencies, the afterload on the ventricle is increased a lot. As a result, the ventricle has to contract harder, or the pressure within the ventricle increases, and the difference between the pressure in the aorta and the end diastolic intraventricular pressure is what is the perfusing pressure for coronary flow. So that decreases coronary flow. Then in case of Takotsubo cardiomyopathy, a part of the myocardium, usually or classically the apex of the myocardium, dilates, okay, and that dilatation results in an increase in its internal diameter and a decrease in the thickness of the wall of the myocardium, resulting in increased tension within the involved myocardium, resulting in increased oxygen requirements. Okay. In acute decompensated heart failure, similarly, there is an increase in both the afterload and the preload of the ventricle, and we'll be getting into the weeds of this later during our discussions on cardiomyopathy and during our discussion on acute shortness of breath. Now, chronically, similarly, you could have hypertrophy, that is an increase in the total amount of mass of the ventricle, with or without myocardial bridges compressing the epicardial vessels. There could be a stenosis into the flow into the aorta, resulting in decreased blood within the aorta and therefore decreased diastolic aortic runoff and therefore decreased coronary blood flow, and also along with that an increase in myocardial mass. So that would be a aortic stenosis. And you could also have subendocardial muscles being stretched by a mitral valve prolapse, okay, resulting in local ischemia and therefore chest pain. Okay, so these are the causes of myocardial ischemia. Now, notably, all of these can technically are activating nerves from the cardiac plexus. So it would be very difficult to differentiate them from each other without further analysis of what might be the triggers or what might be the exact history. Okay. Now, in case of myocardial inflammation, it is myocarditis, and myocarditis again usually has no relation to activity. That is how you differentiate it. That is why I was insisting on clubbing the patients into those that satisfy the definition of unstable angina and those that don't. Okay. Now, in case of chronic myocardial inflammation, there is an entity called chronic chest pain syndrome that happens characteristically with sarcoidosis. Okay. Then you can have esophageal ischemia that happens with esophageal motility disorder, specifically esophageal spasm, and you can have esophageal inflammation, which obviously happens in case of esophagitis of any cause. Okay, there are two types of esophagitis that don't cause pain typically, that is post irradiation and your eosinophilic esophagitis. This we'll talk about when we talk about dysphagia as well. Now, finally, we could have pancreatic inflammation. So obviously, acutely that would be acute pancreatitis, and in a chronic setting that would be acute pancreatitis, and in chronic setting it would be chronic pancreatitis. And persistent esophageal inflammation would happen with gastroesophageal reflux disease. Okay. So that concludes a discussion on how you would approach your chest pain. And as I have said, the emphasis is on a three-step approach. Okay, what you do is, step one, you rule out history primarily. Okay, rule out acute aortic syndromes and pneumothorax. Second step, you have to decide whether or not the pain is from the cardiac plexus or something else that is from a somatic afferent nerve getting activated, either from the pericardium or from the parietal pleura or from the chest wall. Okay, so again, very highly localized local pressure or mechanical changes in the gravity, the direction with which gravity is affecting the mechanical distortion of the particular tissue will affect those kinds of pain. Now in step 3, what do? We decide whether it fits into the definition of unstable angina. Okay, so with these 3 steps, it's usually quite easy to approach chest pain logically, and you don't need to then be confused as to what to do. Now, just a word on myocardial ischemia. So, myocardial ischemia basically means that there is a mismatch between the myocardial oxygen demand and the oxygen supply that the myocardium is getting. So, the demand is too high and or the myocardial oxygen supply is decreased. Now, oxygen demand depends on what? It is determined by something called the tension time index. That means how much is the average tension developed within the wall of the myocardium times the total amount of time that the myocardium is contracting. So that is obviously a constant, it's continuously doing so. Okay, so we are essentially only interested in the tension in part of it. So the tension developed by the Laplace function is equal to your pressure within the ventricles times the internal radius of the ventricle divided by the width of the ventricular wall. Okay, so we've discussed that previously. Now myocardial oxygen supply depends on 2 things. It depends on the oxygen carrying capacity of blood, and see, blood has a very good oxygen carrying capacity. So at rest, usually anemia or is not able to cause chest pain. It may cause palpitations, which the patient may describe as a retrosternal discomfort, but at rest it will not cause discomfort, chest pain during exertion. Also, even with severe anemia, because it's usually quite chronic, it is well compensated and the patients don't develop chest pain. Okay, that you would classify as unstable angina. You would rather say that there is retrosternal chest pounding. Okay, so that we'll come to that in our discussion on palpitations. When it really becomes problematic, when there is a decrease in coronary blood flow. So as I just discussed, coronary blood flow is determined by the pressure gradient, and the pressure gradient is, because coronary blood flow occurs primarily during diastole, it is between the aorta and this is the coronary artery arising from the aorta and the pressure within the LV lumen. Okay, so the aortic pressure minus the in diastole minus the LV pressure in diastole is what is the pressure gradient that is driving blood flow into the coronary circulation. Okay, and then obviously it is inversely proportional to the resistance within the coronary blood flow. Okay, so we've discussed these 2 things in detail. Now let's just talk about this in a little bit more detail. For a ventricle that has a given internal radius and a given wall width, the pressure generated depends on 2 things. It depends on the afterload, okay, and it depends on the preload. The preload being how much volume or how much is the LV end diastolic volume, and the afterload basically being the mean arterial pressure within the systemic circulation. Okay, so what might increase the preload? So preload increases when there is congestive heart failure. Okay, because there is RAS activation, renal hypoperfusion is occurring because the RAS activation is there, so the total body water has increased because RAS is causing the kidneys to hold on to more water. It might be to mitral regurgitation because part of the ejection fraction is going into the low pressure system, that is into the left atrium, and then that blood during the next cardiac cycle is coming back into the left ventricle. Okay, it may be due to congenital heart diseases with a left to right shunt. Okay, because there is increased flow passing through the pulmonary circulation. Okay, now it can be due to increased afterload. So the afterload could be increased because there is a stenosis to aortic outflow, or there could be systemic hypertension. There is an increase in the systemic blood pressures. Thirdly, you could have an increase in both preload and afterload, and this happens in one condition, that is your aortic regurgitation. Okay, and actually the most characteristic historic entity or a historic finding that you have in patients with aortic regurgitation is palpitations followed by the development of nocturnal angina. Okay, and that is nocturnal angina, as the name suggests. Okay, so we'll get into that when we're talking about valvular heart disease. But nocturnal angina happens because in aortic regurgitation you have a increase in preload, because whatever was the ejected blood has come back into the ventricle during diastole, and there is also an increase in afterload because you're trying to eject a lot of volume through normally sized aortic orifice, but there's a lot of volume. So because of that, the pressures that need to be generated to increase the flow rates are higher. Okay. Now, for a given oxygen carrying capacity of blood, as I said, for a given HB, the myocardial oxygen supply is determined by the myocardial blood flow. Okay, which obviously in turn is dependent on what? It is dependent on the difference in the pressure. So the aortic pressure in diastole. So if the aortic pressure in diastole falls down, there will be a decrease in your coronary circulation flow or blood flow within the coronary circulation. So say you have a very excessively compliant aorta. Okay, that could happen. Also, this never happens in real life. Okay, or if you have a decrease in peripheral resistance, because how much the blood goes into the periphery versus goes into the coronary circulation is determined by the resistance within the peripheral circulation and the resistance within the coronary circulation also. So if the resistance within the peripheral circulation is less, then most of the blood will go into the peripheral circulation rather than going into the coronary circulation. Okay, so we term this aortic runoff. Okay. Now, the second thing is LV pressure in diastole. The higher the LV pressure in diastole, the lower the difference in pressure, and therefore lower the coronary circulation blood flow. So let's see what determines the LV pressure within diastole. So it depends almost exclusively on the compliance. Like any pressure depends on the volume times the compliance of the vent of the structure within which the blood is housed. So the volume is the LV end diastolic volume, and the pressure is obviously the LV compliance itself. The compliance is the LV compliance itself. Okay. So these are the two factors that determine it. So say you have hypertrophic cardiomyopathy, there because it is a concentric hypertrophy. Usually the internal diameter of the LV is decreased and the LV compliance is decreased. So in that situation, you get pain. Why do you get pain? Because there is an increase in the LV pressure in diastole, and that decreases the blood flow to the myocardium during diastole. Okay. Now, third thing is resistance to coronary blood flow. So resistance to coronary blood flow is actually has three components, which are termed R1, R2, and R3, and we'll just get to that in the next slide. So what are these three components? So resistance to myocardial blood flow, which is in turn, it depends on three specific things. Okay, it depends on the resistance to flow in the epicardial vessels, that is the vessels that are there in the pericardium, just at the most superficial part of the heart. Okay, this is termed R1. Okay, now this is physiologically trivial, and in a healthy, particularly athletic individual, it is almost non-existent. Okay, most of the resistance is within the R2 vessels, that is the precapillary or the prearteriolar arteries, and or within the precapillary arterioles and the intramural capillaries, that is called R3. Okay, but importantly, when a patient has got atherosclerosis, it is actually the resistance within the epicardial coronary arteries that is maximally increased. So the primary site of atherosclerosis being a problem that happens with large to medium-sized vessels. Okay, it primarily affects the epicardial vessels. That causes luminal narrowing. That is, it decreases the internal diameter or radius of the affected vessel, and that results in an increase in resistance to myocardial blood flow. Okay, and we'll be getting to this in great detail in subsequent videos. So now coming to the end of the video. In subsequent videos in this series, I'll be discussing when to suspect an acute aortic syndrome in more detail. The second thing I'll be discussing is what happens when you have a pneumothorax and how to diagnose it. Okay, in both situations, the relevant imaging will go along with our discussions, and we'll go into the depth of our understanding of those entities, even in radiology. Then we'll come to understanding myocardial ischemia. Okay, and the discussion on esophageal and pancreatic disorders, which would also mimic cardiac pain, as we've just discussed, will be in the gastroenterology symptom analysis series, and you'll have to wait a bit for that. So that's it for today, and thank you for watching. I'll see you in the next video.